in adult congenital heart disease. She did her pediatric residency at Johns Hopkins, and this was followed by a pediatric cardiology fellowship at UCSF, University of California, San Francisco. She subsequently completed an advanced cardiac imaging fellowship at the Boston Children's Hospital in the Harvard Medical School system. She spent 2 decades of her career at the Minnesota Children's Hospital and the Minneapolis Heart Institute, leading congenital cardiac MRI, congenital echo, cardio-obstetrics, adult congenital heart disease care. And she developed one of the first congenital CT programs in the world, and everybody has learned from her thereafter. In 2021, Dr. Hand joined the University of Utah, the Intermountain Primary Children's Hospital. She was tasked with the very difficult challenge of congenital cardiac imaging education. She's there the director of the non-invasive congenital cardiac imaging program, and she's a professor of pediatrics and internal medicine and the Lloyd Tiny Endowed Chair of Pediatric Cardiology. Dr. Hand's research focus has been decreasing comprehensive and cumulative diagnostic risk in patients with congenital heart disease. She has been, as I said, a pioneer in the development and the use of CT in patients with congenital heart disease of all ages, from neonates to adults, and she truly self-taught herself how to do this. In addition to all her academic achievements and amazing clinical skills, Dr. Han is a role model for women in cardiology. She's a wife and the mother of 2 teenage daughters, and she defines herself as an advocate for younger parents in medicine who are trying to juggle the responsibilities of a busy medical career and parenthood. Dr. Han, welcome.
Well, thank you for that very generous introduction. It's been wonderful to be here, and the welcome has been very warm. Thank you all who came to dinner last night. There was about 30 people there, all who took time from their families, and so I really appreciate that. So thank you for the invitation. So I have a lot of slides, and what I'm going to do is show a lot of pictures because I want to show you the potential of CT in congenital heart disease. And so we'll go through the evolution of cardiac CT, and then the risks of cardiac CT, focusing on radiation, which has been kind of the biggest holdup for this technology. I'm going to go in detail about coronary artery imaging and PVR placement, and then I'm going to go through kind of just a gallery of examples of complex lesions, and I want to end with what are the challenges that we face in terms of cardiac CT and congenital heart disease. We'll talk about workforce, reimbursement, and then also education. So looking at, just going to start my timer. You guys know this, you live this. And so this is looking at the changing mortality and the changing prevalence of congenital heart disease. And so this is over a 20-year period. You can see that most mortality went from infancy to adulthood. Most patients with Fontans are now over the age of 30. When you look at the prevalence since the year, right here, 2012, there was equal numbers of pediatric and adult patients. By 2030, 2/3 of patients are going to be adults, and there's an increasing number who are over the age of 60. And so these patients, for the first time, have both congenital and acquired heart disease. Looking at the evolution of cardiac diagnostics, when we first started doing cardiac surgery in our field, the only thing they really had was cardiac catheterization. Since then, we have cardiac echo, we have cardiac MRI, and then CT really is sort of the newest modality that we're applying to patients with congenital heart disease of all ages. We now have 2-dimensional information, we have 3-dimensional information, we have 4-dimensional, which I like to think of hearts in motion. We're able to look sort of inside vessels and do sort of what we call angioscopy. And we're now getting to the point of doing physiologic imaging. This is an example of FFRCT. This is a patient of mine who was 45, had an anomalous right coronary artery, and had an abnormal FFRCT showing ischemia. We're also able to look at MRI tissue characterization and flow. And so I think we have a lot of tools now that really can help us with the both anatomy and physiology of congenital heart disease. I wanted to actually go back to ASD closure and just show what we have and how we got there. And so if you look at any article, anything, you'll say ASD closure is a safe procedure with almost no morbidity or mortality. And when you actually look at the history of cardiac surgery, it really was quite an accomplishment that we have what we have now. And so the first ASD closures were indirect, then open. They did hypothermia with inflow occlusion. They gave the surgeon 5 minutes and 30 seconds to do the operation, which wasn't quite enough to get a good repair. Little High did cross circulation with the parent as the oxygenator. And so you hooked up the parent to a small child and did the operation. And with that, he had 28 survivors of 45 operations. The Mustard actually started doing cardiopulmonary bypass with putting monkey lungs in these two little tubes here and tried to use monkey lungs as the oxygenator. And then Gibbon is now credited with the first sort of cardiopulmonary bypass on an 18-year-old woman for ASD closure. And when you look at the other 3 patients that were in those reports, it's actually fascinating. 2 of the patients had the wrong diagnosis. And so one of the patients got to the operating room to close an ASD and turned out they had a large PDA. The other patient had not only a small ASD, but a VSD and a PDA. And these patients all died. And so when Lilla High and DeWall started thinking about a cardiopulmonary bypass machine, I love this quote. It says, "Avoid libraries and avoid literature searches, as I want you to keep an open mind and not be prejudiced by the mistakes of others." And with that approach, they actually developed the bubble oxygenator, and then down at Mayo, the membrane oxygenator. And so we take for granted the safety of cardiopulmonary bypass, and I think that we owe it to these pioneers that led the way for us. Now, this is examples of ASDs in adult patients, and so this is the type of information we can now get from CT. These actually are coronary sinus septal defects. These were all in patients with right heart failure. This one actually had a TAVR and still had heart failure symptoms, and turns out that when you look back at her CT, she had an unrecognized coronary sinus defect. This is actually a woman who was short of breath in pregnancy, and this is actually inferior sinus venosus defect, and we've seen 5 of these now in patients who've had previous cardiac surgery. When you think of where the surgeon puts their cannula, it's right in the inferior vena cava, and so you won't see this unless you're looking for it. And so we've had a lot of patients who had surgery before 1980 when there was no echocardiograms, and you could miss these. And then this is actually a superior sinus venosus defect. So not only have we had increased surgical and cardiopulmonary bypass, we really have great diagnostics. And not all congenital heart disease is going to present in childhood. These are all adults that presented with congenital heart disease. This was actually a 41-year-old male who had flutter, and he said ever since he was a child, he would start coughing whenever he exercised, and we put him on the treadmill, and because of his choroidal membrane, he would go super systemic in his pulmonary arteries every time he exercised. This is actually a 54-year-old, and she was told she had pregnancy-induced hypertension with her last baby, which was 30 years prior to the CT angiogram. She actually had acquired aortic atresia, and you can see that there's almost no connection whatsoever between the proximal and the distal aorta. And these women were all told that they were poor athletes, and it turns out they had huge ASDs with large shunts. And so keep in mind, even for your adult patients, they can have unrecognized congenital heart disease. So looking at the evolution of cardiac CT, this is actually Dr. Hounsfield, and they would put these patients, this was actually like a water bath, and you'd put the head in there. And so this was the first image in a medical journal of a cardiac CT, and it's of a brain tumor. The slice thickness was 1.3 centimeters. It took about an hour or 2 to get the images, and took much longer to sort of process them, and so there was no ability to see cardiac motion. And that really started to change when instead of getting one slice at a time, we started getting multiple slices at a time. And so this is the first picture of a coronary angiogram by Dr. Stefan Achenbach, who started Society of Cardiac CT in 1995. And since then, we've gone from first, second, third generation, now photon counting volumetric scanners. And if you look in the literature, in 0.6 seconds, you'll get almost 5 million articles for CT in congenital heart disease. So looking at our scanners and sort of what we're doing, there's 2 different things that really matter in terms of looking at the heart. One is spatial resolution, and that's your ability to sort of differentiate between 2 points. And so when you think about a pixelated picture, like what is the detail that you're seeing? And then temporal resolution really is your ability to freeze motion. So think about an Olympic athlete doing something, your ability to sort of watch them in motion is really your temporal resolution. And when you look at scanners, the gantry rotates around the patient, and then your X-ray tubes, you either have 1 or 2, and if you have 2, the temporal resolution is twice as fast, and then the detector converts this into a picture. So the newest scanners that are coming out are called photon counting scanners, and those actually have resolution down to 0.2 millimeters, which is pretty incredible. And instead of averaging the photons, you actually can measure the individual energy coming through, and so it pretty much eliminates noise, and it also eliminates metallic artifact. I saw one picture of an ortho procedure, and you could almost see the screws and the stents. You can see, so it's beautiful. And so these, I think, will be the way forward. Some of them are in clinical use, but they're pretty new. So when I talk about imaging, I want to talk about sort of anatomic versus functional imaging. When I talk about anatomic imaging, what we can actually do now is target the radiation to a single phase of the cardiac cycle, usually 5 to 10%. We can do it in systole or diastole, depending on what we're looking for. And these are all examples of scans that were done in a single heartbeat. And so this is actually a neonate that had mixed total veins. The left upper went to the innominate, but you can see here the pulmonary veins coming to a confluence. It then drains into the left atrium, and this actually drains separate. This is a truncal valve. This is a patient who had single ventricular heart disease on mechanical support and had sort of kinking of his innominate artery before it gave rise to his BT shunt, double out the right. This is actually a neonate, 2 kilos, where you can see this type of detail in transposition. And this coronary transfer was very difficult because they had very limited room to do their coronary button. So then we talk about functional imaging. And when we do this, and this is one of the reasons that radiation exposure is much less now, is that we can actually give full radiation for part of the cardiac cycle and just give a fraction of that for the rest of the cycle. And so for all of these images that you'll see today, we give full radiation for 5 to 10% of the cardiac cycle, and the rest of the cardiac cycle gets 20%. And so you'll see some of the pictures are really clear, then a little bit blurry, and that's actually on purpose. So when we look at comprehensive risk in congenital heart disease, the first thing is we need to have an accurate diagnosis. When you think back to those ASDs, they were taking the patients to the operating room with the wrong diagnosis. And so we really need to make sure that our diagnostics are accurate to give our interventionalists and our surgeons the best information available. And CT and MRI are almost never for screening in congenital heart disease. And so almost all the time, they have complex disease and you're doing the study for a specific question. The current ACHD guidelines recommend serial screening every 1 to 5 years for moderate to complex disease. And so when you think about that, you want to do a very targeted exam for the clinical indication to decrease their comprehensive risk throughout their life. For sedation and anesthesia, for the older CT scans and for the MRI, we used to do a lot of sedation. But with the newer scanners, the image acquisition is so quick that it's very rare to need sedation even in pediatric patients. And then one thing we'll talk about is radiation exposure. So this is looking at anesthesia and neurodevelopmental risk, and this is really an issue for people that take care of pediatric cardiac patients. And this meta-analysis really did show that when you give anesthesia during the sensitive periods of brain development, there are adverse effects lifelong. And so it's one of the things we take into consideration when determining which imaging to use. And this is actually looking at radiation risk. And for some reason, this really got into the press. And so during this time, people were canceling their CT scans and asking to go to the cath lab instead. There are photons in the cath lab, but we tend to not worry about them as much for some reason. And I think this is looking at adult congenital heart disease, and this came out saying that your relative risk of cancer is higher than the general population. And in a lot of these papers, they're saying that is causal to radiation exposure during diagnostics. And during this era, it was mostly catheterization rather than CT. But these articles are really important to look at. So these are the 2 articles on which all of that data was based. And so this was a survey in England, and they looked for almost 20 years. And they actually, so a millisievert is how much radiation you're exposing the patient to. And we all get radiation all the time. So the average for a person just walking around the planet is we get 3 millisieverts per year. If you live at altitude, you get an additional 1.5. And so 0.25 millisieverts is the average background radiation, to put these in perspective. And when you talk about milligray, it's basically how much radiation you get from 1 millisievert. And so this actually had very high doses in this study, from 30 to 70 milligray. And the interesting thing is they actually used as their control group, considered no risk from radiation, those who received less than 5 milligray. We almost never give this dose anymore. Almost all of our patients and all of our CTs are getting a radiation exposure that was considered the control group in the study that showed an association with cancer. The second study that is actually very humbling is this one. And so this actually is, again, a survey looking at all CT scans in pediatric patients. The variation in dose was 0.3 to 69 millisieverts in pediatric patients. And I actually did review an outside CT the other day where a person just getting an aortogram got 25 millisieverts, where if we would have done it, it would have been less than 1. And so I think that it's a very humbling statistic to see. And what their conclusion was that if you got rid of the patients that got over 20 millisieverts per scan, you'd actually decrease the risk of cancer by almost 50%. And so when you look at the historical radiation doses versus what we're using now, I think we really are in a different era. This is 2 studies showing radiation dose in congenital CT, and there's been an 85 to 90% reduction, and that's because of all these different gating techniques and because of doing targeted radiation. And you rarely need the image quality for an adult coronary angiogram in a congenital patient. And so you can really dial down the radiation and give beautiful studies most of the time. And this is one of my favorite studies ever, because this was actually in Pakistan. And what they showed was if you actually standardize your protocols and teach your techs, you can get this reduction in radiation dose. So this was no change in anything other than standardizing protocols and really teaching the techs how to do CT. And they went from having an average of 30 millisieverts per scan to less than 1. And so it's a combination of technology, as well as education and standardization. And I have one quick thing just on radiation dose. And so when you're looking at radiation dose, it's kind of a little bit of a murky subject. And so there's something called your CT dose index, which is how much radiation you give for each slice. You multiply that by the number of slices and get something called a dose length product. And you multiply that by what we call a K factor. And what they've done recently is try to adjust it for age. And so if you give the exact same radiation to a pediatric versus an adult patient, in the literature, they will estimate that the pediatric patient got 5 times higher dose because they're trying to sort of account for all these different things. And so I think because of this, people are going back to DLP because it's gotten too confusing to try to understand all this and compare things. And so this is actually what's in the literature regarding radiation exposure. And so here, these are 2 articles in Circulation, 2014, 2016, and it really lists CT as having more radiation than any other modality, 14 to 16 millisieverts. And so we got together with 4 centers that were really doing a lot of congenital CT, and we developed a prospective database to actually look, because we knew that this information was sort of outdated. And so for 1,300 scans, our median millisievert was 1. And so I think that when you do this work, you really can get the doses down quite well. And if you actually look over 18 years of age, the age-adjusted dose was 2.8 millisieverts, and that's using the adjusted K factors. And so when you think about the one study saying that less than 5 millisieverts is your control group, even in our adult patients, our median dose was 2.8, and the range was up to 4.89. So our patients are getting less radiation than historically by a long shot. And then I think this is really important. So this is actually looking at, this is why you should probably get a radiology overread of your congenital studies. So this is actually looking at 2 studies showing the intrinsic risk of cancer for patients with congenital heart disease. And this is very sobering. So if you have a major chromosomal defect and you were conceived with IVF, your relative risk of cancer is 38 times higher than the general population. And when you're looking over here, this is another survey showing similar information, even a VSD has 10-fold higher risk of hepatocellular carcinoma. Those patients don't get radiation. So our patients with congenital heart disease, because of their anomalies, are at a much higher intrinsic risk of malignancy. And I think the link to cancer with the diagnostics is probably multifactorial. People getting a lot of scans have the most complex disease. They're most likely to have birth defects and chromosomal abnormalities. And so I think it does. So in summary, I think CT radiation dose is greatly reduced compared to historical estimates. Education and technology are equally important. The DLP is the most objective measure of scanner output, and I think that's what I've been looking at primarily. The links to cancer are multifactorial, but I do think that that intrinsic susceptibility really is one of the things we really do have to use dose optimization in the as low as reasonably achievable principle to decrease the risk to our patients now that they're living longer. So in terms of recommendations for CT in clinical practice, it really, ever since 2006 all the way up to 2020 with the newer guidelines, it's listed as appropriate by every society for evaluation of complex congenital heart disease. So now I want to actually switch from radiation to talking about coronary artery anomalies. And so when you look at pediatric patients, we have intrinsic abnormalities, which is like anomalous aortic origin of the coronary artery, coronary atresia. We have coronaries from the pulmonary artery, fistula bridge. And then we also have patients that have had surgical manipulation of their coronary arteries, and they can have either intrinsic problems with that coronary where it was reimplanted, or we also can have dynamic compression. I'm going to show you some examples of that. And then we also have Nikaido, where you translocate the aorta, you can stretch that coronary artery. I'm going to show you an example of Williams syndrome. And then there also is a risk for coronary compromise with the percutaneous valves and the valve-in-valve interventions. And so we have to be aware of all of those. And so when we look at AAOCA and the different subtypes, there's a lot of them. Anomalous left is much less common than anomalous right. But we're really looking for the coronary artery that goes between the aorta and the PA with an interarterial or an intramural course. And so the reason we care about this is actually a great study, and this is looking at myocardial ischemia with AAOCA, and this is the percent of patients that are asymptomatic before death. And so this is one of the worst things to see with a patient in clinic, because you're like, well, I think you're going to be fine, but we know that about 50% of patients, their first symptom will be a sudden death event. And so this was actually a great study because they actually really started to look at what are the features that might predict malignant course. And so what they came up with in this study is an intramural course, a high orifice, a slit-like orifice, and the amount of intramural segment. And then there weren't enough events in the right coronary group to be definitive, but it's probably that the risk factors are similar for both. And you actually have one of the, at Texas Children's, they have a very good coronary program. And so I just want to show you some examples of what we're talking about. So this is 2 examples of anomalous right coronary artery from the aorta. And you can see in this one, the coronary artery is nice and wide open. There's acute angulation, but there's no ostial narrowing. There's no intramural course. In this one, you can see the ostium is very narrow. When you can hardly open it up at all, this is the intramural course, and you can see the caliber change from the proximal to the distal vessel. And then when you actually are marching along the coronary artery, you can see that it's really almost like within the aortic wall. And as you come out distal to the vessel, you can see it kind of pop off the aortic wall. When you put it in the vessel view type programs, you can actually get the intramural length of that coronary artery, which is thought to predict ischemia. The other thing we can do is really look at where the coronary comes off related to the aortic pillars. And I think this is really important because I think you can predict who's going to have problems with the aortic valve after your intervention. Some of these actually come right down, and you actually have to resuspend the aortic valve leaflet. And so our surgeons, they love to know what is the relationship of that coronary ostia to the aortic valve pillar, and do they need to worry about interrupting the aortic valve during their repair. And so the height and then also the relationship to the aortic pillar, I think, is an important thing to show. And now these are examples of intramural versus interarterial. I think this is really an important point. And so this is 2 anomalous coronaries. This is anomalous left from the right, anomalous right from left. And you can actually see how narrow this vessel is here and how it normalizes as it exits the root. So this is interarterial and intramural. This is actually a 63-year-old patient who had an interarterial course, but you can see that the caliber of the vessel is normal throughout, and so that's probably a different risk profile. This is actually a patient who's a pediatric patient with a single coronary artery. And so sort of differentiating what's within the wall versus what's between the 2 arteries, I think, is important. And this is actually a case that an adult surgeon asked me to look at 2 days ago. This is a 64-year-old, and they were going to take her to the operating room for her anomalous left, but she actually has what we call an intraseptal variant. And so in that case, the coronary artery does not go up in between the aorta and the pulmonary artery, it actually dives into the ventricular septum. There are some reports of ischemia with this, but it's really thought to be more of a normal variant. And you can see here, the coronary artery is wide open. You can see right at the origin, nice and round. And so this is something to be aware of because most of the time, these do not need to go to the operating room. So just looking at that, I think there's interarterial and intramural. There's interarterial and intraseptal. And I think the mechanisms of ischemia are thought to be very different. So with this type, it's ostial narrowing, acute angulation, wall stress with exertion, in addition to probably dynamic compression of the pulmonary artery. And with interarterial, it's really the acute angulation and then the dynamic compression between the aorta and the pulmonary artery. And which type of stress we use for these, I think, is very important because every single guideline just says stress imaging, but doesn't say what type. And I think this type may be positive. The one example I showed earlier was actually an FFRCT done with nitro, with vasodilator, and that might be positive, but these are never going to be positive with vasodilator tests because the proximal coronary is just fine. And so when you look at FFRCT and you sort of look at the different types of stress, they're starting to think about doing dobutamine FFR to show if with increasing blood pressure and less time in diastole, what is the actual mechanism. And so I think we have to be really careful and very thoughtful of what kind of stress tests are we going to use based on the patient's symptoms and the anatomy of their coronary. And this is actually a patient of mine who was a 17-year-old, super competitive athlete, so on the football field every day for years, and then he's at a birthday party playing kick the can, and he goes down and had to get defibrillated. And I think that using multi-modality imaging and being able to show that there was ischemia in the right coronary distribution really was helpful in saying, okay, this arrest was because of this coronary. We don't need to put a defibrillator in and look for sort of channelopathies and other reasons for his arrest. This is a neonate. This study was actually done to look at the aorta. We were able to show that there was left coronary artery atresia. This is like a 3-kilo baby with a heart rate of 160, but this is the type of detail we can get with current scanner technology. So I'll go through 2 examples. So those were all anomalous aortic origin. This is actually the pulmonary origin of a coronary artery. So this is actually a neonate. I read his echo. It was his 4th echo. There was one picture where I thought, I wonder if that coronary comes from the pulmonary artery instead of the aorta. And so because he had a big VSD and systemic pressures in the right ventricle, totally asymptomatic, but the baby did have not only an anomalous right coronary, but an anomalous left. And so when you look here, here's the aorta circumflex, here's the pulmonary artery giving rise to the right coronary and the left. And so had to have a reimplantation of that coronary artery. And then this is a patient of mine that I just find fascinating. So we in pediatrics sometimes think we should look at coronaries with echo, which is, I think, typically not the best idea. But in this case, I really thought I could see the normal origin of the left coronary artery. I thought with color, I can see color in the proximal segment, and there's some flow into the pulmonary artery. And so I followed this patient for years thinking that she had a coronary fistula. But she always had this little bit of a resting sinus tachycardia that bothered me. And so she's one of the times when when all the radiation stuff was in it, the family canceled a CT 3 times. And so finally I said, if you don't get a CT, you need to find another cardiologist. And so I was in the scanner, and she actually had her circumflex and her LAD coming from her pulmonary artery. And her entire distal bed was fed by her right coronary. And so I think that, you know, for these patients, I no longer trust echo. If there's any symptoms or any clinical suspicion, we get a CT in these patients. And then this is something I don't know what to do with. This is actually a case we just had about a month ago. This is a competitive athlete, exertional chest pain. And so we did this to look at his coronary origins, which are just fine, totally normal coronary origins. But he does have a long sort of myocardial bridge. And when you actually follow this, you can actually see it dive into the myocardium. What to do about it, I have no idea. He had a stress test that was totally normal. The cardiologist said if you ever have symptoms, go get a troponin, and that was normal. And so I don't know what to do with this, but we can take nice pictures of it. So that's sort of intrinsic anomalies. And now I'm going to switch to talking about coronary anomalies after congenital heart surgery. And we all know that coronary anomalies are common with transmission of the great arteries. And this is actually looking at 2 studies in pediatric patients. And what actually happens is typically patients will either have a really rocky operative course, which is a risk for coronary issues in the future. And then around 8 to 10 years of age, there's an increase in coronaries. And I think the thought is that kids start to get competitive and push themselves past where they're comfortable around 8 or 9 years of age. And so it's probably not a change in the patient, it's a change in what they're expecting of themselves. And so a single coronary orifice or 2 origins close to each other was one of the highest risks, and also major operative events. And so when the patient has a really rough operative course, there's a chance that there's an issue with the coronary. And this is I really like this picture. It actually shows coronary commissural malalignment. So when you think about your surgeon having to take this coronary and put it onto a different one, when the coronaries and the commissures aren't aligned, the sort of space to put that button isn't optimal. And then also if the coronary comes off close to a commissure, you also can't get a really good button. So these are things that aren't in the current sort of risk paradigms, but probably are relevant. And then this is something that you guys like to see as adult people. So this is actually Paul Carey. He does a ton of great work. He's an adult congenital EP doc, and they actually looked at patients over 18 years after the arterial switch. And then you can see that like during adolescence, these patients really do great, and then sort of in young adulthood, they start to have more coronary events. And he found very similar single coronary artery post-operative events were sort of predictors. And so this is why like when you have an adult congenital patient, you can't just say arterial switch, whatever. You have to actually look back to his operative notes and look back to the neonatal history to know sort of what risks they are of coronary events. And this is just examples of what we sort of see. So this is coronary osteoatresia, or not atresia, but stenosis in a patient who had arterial switch. Here's another one. So you can actually see coronary lesions. These are patients who are high risk for coronary compression with a percutaneous pulmonary valve because of the relationship of the coronary artery to the right ventricular outflow tract. This is actually a patient, 8-year-old patient of mine, who had a Nikaido, and with a Nikaido, you actually sort of carve out the aortic root and you move it over, and you can really stretch the coronary artery. And so you can see mid-right coronary lesions after the Nikaido. And then our surgeons like this type of information, because when you have a coronary going directly past the sternum, you can actually show them exactly where that is in terms of where to cannulate and which sternal wires to be extra careful with. And these patients really are at risk for coronary issues with sternal reentry, and it's also been shown with percutaneous pulmonary valve to also be a risk factor. So I think these types of details are important. And I'm going to show you, these 3 cases have happened within the past year, and I think it's fascinating. So typically when you're doing a coronary image, you just are looking at the single interval that's going to give you a picture of that coronary artery. When we have had patients with exertional symptoms in the past year, we've actually done a functional CT, and this is actually looking at a patient. Here's the LeCompte, pulmonary arteries anterior to the aorta. These are the reimplanted coronary arteries. They're actually, the reimplantation is beautiful. But look at this. This is the coronary during the cardiac cycle. And so with systole, the coronary really is between the aorta and the pulmonary artery. And with maximal exertion, when you have systemic PA pressures, you can start to get compression similar to an anomalous left. And this is another, so we started thinking about that. And this is a patient who came in, 13-year-old male. He had transposition. He did have coronary anomalies, but had an arterial switch doing great. No symptoms whatsoever. And then he's playing basketball and has a VFib cardiac arrest. So he comes to the hospital, gets a catheter presentation, coronaries look great. And they said, well, let's get a CT just to make sure. This is like 3 days later. And I said, I think that this coronary could be compressed by the pulmonary artery with exercise. And so at the time, when I first got there, we were doing perfusion MRI with adenosine, which I think is going to be normal because your proximal coronary looks fine. And so we actually took him to the adult hospital for people who know how to do really good stress tests. And he had symptoms, ST changes, and wall motion abnormalities at heart rates above 160. This is another case where the proximal coronary is patent, but with exercise, he's having compression. And so I think that's an important thing to note. And then one other case of that, this is actually an 18-year-old with L kappa. And so he had an anomalous left coronary from the pulmonary artery. You can see here that the surgical site is gorgeous. Your coronary is absolutely wide open. Here you can see the origin. But again, you can see the coronary right here is between the aorta and the pulmonary artery. And just how we talked about for AAOCA, that an interarterial course is at risk for sudden death, we're actually creating an interarterial course as part of our repair for some of these patients. And so I think this is something just to be aware of. If you have someone who has exertional symptoms with a history of coronary manipulation, we've started doing functional CTs on these patients to actually look and see is there compression or changes in the relationship with the coronary artery during the cardiac cycle. And this is just an example of a patient with an arterial switch. And like in this case, there'd be no issue whatsoever. For the coronaries, because they're nice and wide open, they're sort of far away from the neopulmonary valve. And so I think based on symptoms, we're sort of changing how we evaluate these patients. So recommendations for testing after arterial switch. I mean, everyone thinks you should get a picture of the coronaries at least once. There is recommendations to do serial perfusion, but really if you have a CT that shows perfectly normal coronary arteries, I don't know what we're looking for with the perfusion studies, and I feel like sometimes the recommendations haven't caught up with sort of the capabilities. But I do think that for the perfusion imaging, it's important for some of these patients to do more stress imaging that is like dobutamine than looking for coronary vasodilation with adenosine. I don't think we can take all the things that the adult guidelines have and just apply them to our patients. I think we're going to do the same. And so this is actually another case, once we started thinking about dynamic things with Williams syndrome. This is a 13-year-old girl, exertional chest pain. So again, we said, why don't we do a functional imaging? We can look at the coronary arteries. And so this actually showed that her coronary origin was nice and wide open. Right here you can see that, but here you can see sort of her supravalvar ridge, here and here. And I thought that because this is actually a diastolic image, it really was limiting the excursion of that cusp, and so the cusp couldn't relax. And then when you looked in systole, the valve leaflet was actually up and over the coronary orifice. And so I told the referring cardiologist, I'm probably completely overcalling this, but I think that there would be sort of a physiologic mechanism for limitation in coronary flow, even though the origin is normal. And on her exercise test, she also had ST changes in her exertional symptoms that were reproducible. And looking back, this has been described before, and so this is JT-CVS from 1997, and you do get adhesion of the aortic valve leaflets to the ridge, and in 45% of the patients that had symptoms, their coronary ostia were completely normal. And so really saying that when you look at a patient with supravalvular aortic stenosis, it's a disease of the entire aortic root. And this was the 8 patients who actually died, and of those, 4 of them had completely normal coronary origins. And so I think you have to look at the leaflet redundancy, the tethering of the leaflets to the ridge in these patients. And so just looking at the chest pain guidelines, I think that they really don't reflect the pathology that we see in our congenital patients, and these patients really need more of an individualized approach. And so a lot of people want to go just by the guidelines, but I think that they're not really fit for the patients that we see. So as far as testing for coronary stenosis, I think if you're completely asymptomatic, a CT or an MRI is going to show you really nice coronary anatomy. I think for what we've started to do is if you have exertional symptoms, we've started to do functional CT or a cine MR to try to look for sort of dynamic compression. And I do think that when we're doing MRI, adenosine is probably going to be good for, we've had a couple of patients that have really tight left main lesions, and I think those have been positive with adenosine. But we really think that if you think that someone may have compression, that doing a dobutamine and actually increasing the heart rate, increasing the wall stress, decreasing the diastolic interval might be more appropriate. And if you're going to do FFR, either invasively or with CT, should it be with dobutamine rather than with the coronary vasodilator? And these are all things that we have no idea. We're kind of making it up. So that was coronaries. Now I'm going to switch to native and bioprosthetic valve dysfunction in congenital heart disease. And so valve dysfunction is incredibly common after repair or palliation. And these patients now, they're living so much longer, they really need multiple interventions throughout their life. And cross-sectional imaging is helping to predict the timing of intervention. It's helping to plan intervention and then also to evaluate for post-procedural complications. And I really think this is a case where the heart team or the valve team is so important. And so this is actually fascinating. This is adult congenital admissions. You guys will like to see this as an adult hospital. This is actually looking at an inpatient database of 195 admissions. This is the percent of patients that are above the age of 60. And so these really are patients that need to be cared for. There's a debate about should you do adult congenital in a pediatric versus adult hospital. I think that an adult hospital knows how to treat adults. And so when you looked at this, there was a 95% increase in valve procedures during this time frame. And this is actually looking at intervention in England over about a 20-year period. And the thing to notice here is that there was a 3-fold increase in congenital heart procedures. There was a 2-fold increase in patients less than 10, but a 6-fold increase in patients above the age of 60. And so I think for the structural interventionalists, adult congenital heart disease has definitely become a part of what you do. 75% of intervention is valve related, and of that, the pulmonary valve is the most common, which is why we'll spend some time talking about that. So pulmonary valve dysfunction is common. Percutaneous valve is not inferior to surgical. And the long-term complications have been primarily endocarditis and stent fracture. And then we're now having technologies that fit to the native RVOT in addition to conduits. And the current criteria are primarily based on volumes and function. And I think this is a wonderful study, actually not this one, next one. This is looking at pulmonary valve replacement makes the patients feel better and their RV recovers. And so this is actually showing end diastolic volumes, right to left ventricular ratio, and their New York Heart Association class. People feel better and the RV recovers using our current criteria. But this study by Dr. Anne Marie Valenti at Boston really is sobering. So this looked at 452 patients who had pulmonary valve replacement at a median of 25 years of age. And when they looked at the median follow-up of just 6.5 years, their primary and secondary outcomes were things like arrhythmia, heart failure, death, resuscitated sudden death. And they met that endpoint in 17% of patients within 6 years. And so that's, I thought, quite high. When they looked at it, preoperative arrhythmia, BMI over 30, chromosome abnormality, and then by imaging, the end diastolic volume was not associated with outcome. So many times we're saying a patient should go when their end diastolic volume is 160 and their end systolic volume is over 80. And when you actually look at the data, that doesn't predict anything. But what did was decreased ejection fraction, mass to volume ratio, so right ventricular hypertrophy, and age at PVR. And so it's very likely that our guidelines will change as more prospective data comes out about the timing of this. So one thing about the RVOT, so again, talking about functional imaging, is we have incredible dynamism of the native right ventricular outflow tract. And so you can imagine if you do one cardiac phase, the measurements you get are going to be completely different. And so this is why some cath people say a CT isn't helpful, because if you're getting a single cardiac phase, you may or may not have the information about the size of the pulmonary artery. And so we actually have looked at this, and this is actually a patient with a native RVOT with a transannular patch. This is the dimensions in systole, and these are the dimensions in diastole. And you can actually see that the average diameter is 44 versus 35. So if you're an interventionalist and you want to know what size valve to put in there, or whether you can put a valve in there, if you base it on diastole, you're probably good to go, but systole you're not. And this is where I feel like doing the functional imaging is very important. The other thing is that when you look at a lot of reporting, it's giving you a single dimension. And I think doing the average diameter is really important because you can have ellipticity to a lot of these vessels after intervention. And then what we do with a lot of that now with the company is actually put in, like sort of we get these little, we call these perimeter plots, and you put in the different size valve, or you put in different landing zones and really try to tailor where should the valve go for this patient. Predicting coronary compression, most of the patients that have issues is because of coronary anomalies, and then also if the coronary runs very close to the RVOT or the sternum. These are kind of the current predictors of that. And I kind of like to think about it this way. If your coronary comes off really high and has to drape under the pulmonary conduit, I think that's much higher risk of compression. And this is actually a CT angiogram where we thought this one probably would be an issue. And so we did take her to the cath lab and do balloon size, and you can see the coronary stenosis. And then here, if the coronary is between the aorta and the pulmonary artery, it's obviously high risk based on your landing zone. And so these are what I like to call intraluminal views. And what you can do with these is open up the RVOT and then look at the coronary and the relationship to the RVOT, and sort of whether or not your coronary is going to be a problem depends on where your area of stenosis is. So in this case, the distal conduit is stenosis and the coronary is right there. And so, so whether you're going to predict coronary compression has to do with the patient's anatomy, the valve you're going to put in, and what the dimensions of those valves are. And like in this case, when you have a bioprosthetic valve, it's thought to be safe because you have sort of like a fixed landing zone, unless you're doing valve and valve where you're going to crack that. And so I think these types of pictures can really help predict the risk of coronary compression. So we do have complications post-transcatheter valve, including HALT, which I worked in an adult group, which I loved because there's so much to learn at the intersection of pediatric and adult cardiology. But they were looking at HALT in TAVRs. I thought, well, I wonder if we get that in pulmonary valves, and we actually do. Also endocarditis, conduit rupture, and coronary compromise. These are the things we sort of look for. And so this is our HALT data. And so what we did is we had 14 patients who had a transcatheter pulmonary valve during the time of review, and we tried to get everyone back for a CT 30 days after their transcatheter pulmonary valve, and 7 of the 12 actually had halt, and 2 had restricted leaflet motion. We have no follow-up. We have no idea what this means. We have no idea how to treat it, but just to know that it's there and that some of the things we're learning about TAVR valve halt probably will apply to the pulmonary valve. And this is just what we're talking about. And so here is a normal leaflet, and you can see how you can hardly see it. It's nice and thin. And this is halt, kind of like a meniscus. And you can see here that in systole that leaflet just doesn't move. And this is considered halt with restricted leaflet motion in the pulmonary position. And what is halt? This is actually out in abstract form. I've still not seen it in publication in a journal. But this is actually explanted core valve and evolute valves. And this is actually from TAVR, not from pulmonary valve. But when you actually look, the acute thrombus is in the first 30 days. But when their second thing was between 30 days and a year, it's already organized. And so I think that if we're going to treat with anticoagulation, our window to do it is probably very early before that becomes sort of like a fixed thing. And this is actually looking, these are from Dr. Evan Zahn from Edwards. This is actually the Altera. And if you've ever seen the Altera, it's got very prominent sort of like prongs to hold it in place. This is actually one example of a perforation. And you can see when they took the patient to the operating room, you could actually see the tine sticking out of the RVOT. And then this is the other case where, same thing. You could see that you should see this, but it should stay within the RVOT. And here you can see that it's actually sometimes poking through the RVOT. And you think of these RVOTs and these big dilated, they're very thin, and it might be a combination of a stiff stent and a very thin RVOT. So as far as endocarditis goes, I think that we all know now that pulmonary valve has a lot of endocarditis, more common with Melody than Sapien. And the other thing is that the endocarditis risk for Melody valve just keeps going up. You never sort of hit a plateau. And this has been shown in multiple studies. And then if you have a residual gradient over 15, your risk for endocarditis is much higher. And so we published this with 6 cases in Minneapolis, and we actually, 5 of these patients had systemic emboli as well. And so the reason that CT I think is nice is it's complementary to echocardiography. The RVOT is very difficult to visualize because it's sort of, where it is, you can't really see it well by TEE or transthoracic. It's useful for periannular complications. And then when you look at the new updated infectious endocarditis criteria, it now says echo or CT. So CT is now considered a major criteria. And this is a couple examples. This is a patient with a double switch. So here is the right ventricle to the pulmonary artery. What you can't see is the venous baffle behind there. And so her echo actually looked okay, but this was her pulmonary valve endocarditis, and you can see the vegetations in here. And when you look at where this pulmonary artery is, it's really kind of diving down, and you can imagine you would not get good echo pictures. And this is another patient with a Melody valve, and you can see here the correlation between the CT image and what they found at surgery. This is a patient within the last 2 months. So truncal valve endocarditis. This is a truncal valve, quadricuspid, central regurgent orifice, lots of leakage. And you can see here, this is a volumetric scanner, not dual source, since the pictures aren't quite as clear. But there is a vegetation right here, and there's a vegetation right here. And so we had a lot of discussions about when we go in there, are we going to replace the pulmonary valve? How many people think this looks suspicious for endocarditis? Wait for him to play. There was no change in the valve function. There was very minimal insufficiency, no increase in stenosis. So the echocardiographer is like, you know what, there's absolutely no change in the echo looking back. There's no change in valve function. I don't think it's going to be a problem. Yeah. So you do that sometimes to be able to see within there, but this was actually the CT. And this is one time we actually went up on the kV. And so we said, okay, there's going to be a stent in there. We're looking for the stuff within the valve stress. And so we actually went from 80 to 100 kV, and we actually increased the baseline dose from 20 to 40%. And we were able to see these mobile vegetations within the pulmonary valve quite clearly. And here you can see the valve struts, and then making sure it's not just artifact from the struts. You can actually see the different density of the material versus the stents. Another case of endocarditis, this is a patient with a mechanical mitral valve and mechanical aortic valve presented with a stroke, unfortunately. And you could see a connection between the left ventricle and the aorta, and also between the aorta and the mitral valve. And so this was actually looking at the 2 valves and looking at an abscess there. And then with some of these reconstructions, you can give the surgeons very nice pictures of the relationships of the valves and sort of where the abscess is going to be. There's also a lot of non-infectious bioprosthetic valve dysfunction. And what you can see here is calcified pulmonary valve, non-calcified pulmonary valve. You can show the origin of the coronary arteries in relation to the bioprosthetic valve. And so I think for a lot of these cases, you can look, this is not going to be amenable to medical treatment, it's going to need an intervention. And so here too, just looking at these tethered leaflets in the prior bioprosthetic valve. You guys know all this stuff from your adult work. Then also looking at mechanical valve obstruction. This is a patient on a dehisced patch without endocarditis. This is an 18-month-old patient of mine with pannus, and this was actually a 24-year-old who had a supraannular mitral valve who developed severe mitral annular calcification. So you can really tell what is the mechanism of obstruction in a lot of these patients. And so what I'm going to do now is just kind of go through examples of sort of other uses for CT. So our surgeons really like this for visualization of VSDs. This is a baby. This is a septomarginal speculation, a huge VSD that was sort of right here and right here. And so that you can give them a view of when you go in to the right ventricle, this is what you are going to see. And this is another one. This is looking at an inlet VSD with some chordal attachments across the tricuspid valve in addition to an outlet VSD. So we can really give them, because once the heart's empty, it's sometimes hard to, with a heavily speculated RV, it's sometimes hard to find these things. And so we like to give our surgeons this type of information ahead of time, and this is sort of, a complex apical muscular VSD. We like to do a lot of Fontan visualization as well. And so this is an old atriopulmonary Fontan. And you can see here that where the atrium goes over the pulmonary artery, there's obstruction, and you can actually see that here. You can see the streaming of contrast. There's always a question about whether or not retained pulmonary valve leaflets are at risk for clot. This kind of proves that, yes, it is. This is actually retained pulmonary leaflets, and you can see a clot within each little valve orifice, and then you can also see stent flow. And so for a lot of these patients, you can actually see flow dynamics in addition to just the anatomy. And this is an example of an extracardiac Fontan. So I think for Fontan visualization, it really can be nice with CT. Also pacer leads. Our surgeons like to see where the pacer leads are in relation to the sternum when they're going back in. This was a patient who had an epicardial lead right over her single coronary artery, also with chest pain. Not sure if it was relevant. And this is actually a fascinating case. So this guy came to us and he was an atrial baffle, and he was having TIAs. And at an outside institution, they had gone from the SVC through a baffle leak into his left ventricle, or right ventricle, which goes to his aorta. So he was actually having his lead paced across his baffle leak. The other things we can see is, for atrial switches, with echo, it's sometimes hard to see the venous baffles. And here you can see a normal venous baffle. Here is a narrowed venous baffle, and this one's like completely obstructed. So your actually superior vena cava injection is going down to your PA. And this is actually a time when you want to have contrast differential between your atrium. This is actually looking at an atrial baffle leak. What you can see here is right there. You can actually see the baffle leak with the contrast differential across the atrial septum. You can see it in sort of 3D right here. So for atrial baffles and things, it can be very nice. Another thing we're starting to do is look at what we call virtual bronchoscopy. These are all done with a single heartbeat. And so this patient actually had complete tracheal rings, and what you can actually see is right here. You can actually see the tracheal rings. They're sort of a fixed dimension. You can see the upper lobe takeoff of that bronchus. This is actually a double aortic arch, and if you do this in cine, you can actually watch the vascular compression. So we're starting to do this instead of bronchoscopy. And in this case, you could see an aberrant subclavian artery with esophageal symptoms but no tracheal symptoms. And so it's a nice way to look at vascular airway. And in this patient, we were actually able to do a virtual bronchoscopy as well as a virtual sort of upper GI. And so you're really able to see this with a single heartbeat, show all of that anatomy. So kind of to end up, I'm going to talk about sort of what challenges we have ahead. So this is actually looking at what they call a technology adoption curve. And so when I first started doing CT, people would say at meetings, you're going to kill all these babies, it's like horrible. And I tried to get this article published for over a year, and it got rejected by 3 journals, and they basically said, we don't publish anything about CT and congenital heart disease. And it was actually showing like 80 patients with submillisieverts coronary. And then in 2019, almost the exact same study got published in Circulation. And so I feel like you can really see within this time period the rapid adoption. And I think that pretty much everybody now is at a point where CT is a really important part of what we do. And so I think that the best use of all of our things is to have every modality at the highest quality, because then you can look at the patient and determine what is the best test with the least risk, because we have everything available, instead of trying to fit everyone into the modality that you do. So who should do this? I think that we have some workforce issues. So this is actually looking at adult versus pediatric certifications. And this is true also for adult congenital heart physicians. And so if you actually look at cardiovascular diseases, 32,000 adult cardiologists, there's 2,400 ever certified pediatric cardiologists less than 70 years of age. And so when you look at these patients, I think it's going to have to be adult imagers that start to take this on, just because of how few pediatric cardiologists there are that do this work. And if you actually look here, adult congenital heart disease, check that out. This was, I think there's up to 400 now, but we really have a limitation of congenital imagers. We also have a limitation of the number of adult congenital heart disease docs we have versus the population. And then the other thing that I think is really an issue for us, and I'd like to spend probably the next decades of my career on this, is we don't have an education platform for CT and congenital heart disease. So when I was at Boston, I did not do a single CT because at that time was thought that the radiation was too high and you shouldn't do it. And so I was at Minneapolis Heart Institute, a great place, great imaging, but there's times I couldn't get what I wanted from the MRI machine. And so I went over to CT and said, let's try to figure this out. And we had an attitude of, we don't know what we're doing. Each scan, we're going to debrief and try to do the next one better. And that was really how we started doing our program. And it really worked out well. And when you look at the 2020 training guidelines, this is kind of silly. They say you should have 100 cases of each valve to be competent for TAVR, mitral valve, that kind of stuff. And they say for congenital, you should do like 20. And so this really, when you look at the article, it's for minimum competency to just be able to see stuff that comes across when you're doing a coronary CT. And so we did publish this, kind of the first thing we're doing is proposed competencies. So we made a list of what do we think you should know to do this, and the next thing I'd love to do is build a course around that for both pediatric and adult congenital heart disease and have modules specific to people's deficits. Because the first course we did, we had pediatric and adult cardiologists there, and the pediatric cardiologist would say, what's the CT scanner, what's the KV? And the adult cardiologist saying, what's the Fontan? And so there was such a disconnect between the knowledge bases. We really need to separate out what do you need to know based on your background. And then what we actually did at Primary Children's, because I came there and I had level 3 training or level 3 experience through cardiac CT, we did this for our younger faculty. So we basically took what the hospital had for CT criteria and we said, let's make a preliminary and a provisional scan. And we have one physician we've actually credentialed this way, and we have another one that we're putting through this process. Because you can't just like sit down with a scanner and start doing these scans. They're very complicated. You have to know what you're doing. And then this is actually, I think, a really important point. And so we were talking about this earlier. So if you actually look at the number of echoes a person usually does, our lab does between 25 and 35 a day per physician. But if you actually look at the pediatric standards, 15 to 20 is probably the average. And if you look at fetal, they do 4 to 5 studies a day. SCMR did a survey in 2014 and 2018, and the median number of scans per institution was 209, and the median scan time was 90 minutes. And then this is the part that's really important. The median physician time to complete a congenital heart MR was 140 minutes. So people are spending about 2 hours per case, and the RVUs really don't reflect that, and so it's really hard to justify. But I think you look in an adult lab, they're doing 10 cases a day, they're doing 30 CTs. And when you're looking at these cases, you really can't do that many. And then this is actually looking, so when you look at congenital imaging, it used to be people did echo, some people did echo and TEE or fetal, and now we have cardiac MRI, and now we have cardiac CT. And so you have a huge variety of different imagers. And when you look at the RVUs, which is sort of like how we sort of measure people's work in the business standpoint, if you do a full day of echo, you're going to have 36 to 50 RVUs based on how busy your echo lab is. If you do echo, but you also do fetal, your fetal RVUs will be about 10 because it's much less. You do 5 to 6 of those a day. And then for CMR and CT, if you do 4 to 5 studies a day, your RVUs are 7 to 10. So you can bill more in one day in the echo lab than you will for an entire week of doing the complex CT and MR. And so this is something I think that we need to address. And I'm using myself as an example here of how work doesn't reflect in the RVUs. And so this is actually how much imaging I was supposed to do. And this is how much imaging I did. So I did 75 extra shifts last year. So I basically did the work of 2 FTEs, and my RVUs are at the 8th percentile. And it's because I'm doing almost all cardiac MRI and cardiac CT. And it's just not really reflected. And then one of our business analysts, I asked him to get this ready for this talk and said, what is the difference in RVUs for people who do MRI and CT versus fetal versus echo? And this is actually what he came up with. And so this is, if you take all the RVUs and you index them to a 1.0 clinical FTE, if you do CT and MRI, you're never going to get above the 20th to 25th percentile. If you do echo plus fetal, since you are having your high volume transthoracic days mixed with your fetal volume, you are going to be, at the 65th to 75th percentile. And if you just do transthoracic, those patients or those physicians are all above the 80th percentile, many of them above the 100th percentile. And so what your work is reflected at isn't necessarily reflected in the way that we measure work currently. So I think that's a challenge for us that we need to figure out. So in summary, I think that cardiac CT is a really powerful tool for evaluation of complex anatomy in patients from the neonate to an adult. Growth in CHD CT is nearly exponential. The more we use it, the more things you see. And so almost every program it's like when you look at the technology, it's like a straight up line curve. In the 2 years I've been at Utah, we've increased our volume 70%, and that's with limiting our current adult congenital patients. And I think that tailored imaging is really important to optimize the accuracy and increase the risk. Like, where should the IV be? How should you do the contrast? How much detail do you need? Do you need functional or a static image? And I think that it's very time consuming, it's poorly reimbursed, and the RVUs do not reflect the work required to process these studies. And then an education platform for expert level performance is much needed. So that's what I'd like to work on. So this is my imaging team, and I do think that congenital heart disease is a team sport like no other. You have to have fantastic techs. And so these are our CT and MRI techs, and between them they have 150 years of experience. And we're now, I like to think about like a NASCAR tire change. It's like a NASCAR tire change. When that patient comes in, you want to be able to get them in and out of the scanner. And if you're talking to somebody, do you know what a Fontana is? They're saying no, and the patient's in the scanner. That scan's going to take you a really long time. And so I think we're really working on trying to get like a level 3 or a cardiac expertise for our techs to keep them here. Because a lot of times they'll get that expertise and then they'll go somewhere else. These are my other cross-sectional imaging physicians. So Dr. Benka has been a wonderful partner for the past year, and we just have Dr. Spencer Barfus and Sonia Jalebzik, who just joined us within the last couple months, and this is our cardiology team. And some of you might recognize Dr. Antonio Cabrera is our current chief. He was at Texas Children's. John Colquitt just came from Texas Children's, so did Judson over here. So we have a Texas contingent with us in Utah. And so you can't do this work without fantastic techs, and it really has to be a global approach to a program. And I think it's really important and adds a lot of value to our patients. So thank you very much for your time. And we have a few minutes for questions if anybody has any.
Thank you so much, Dr. Han. This was a masterful phenomenal lecture, and really eye-opening and very helpful for us trying to build congenital programs at adult hospitals. So my question for you is, we have around 400 ACHD cardiologists for over 2 million adult ACHD patients right now in the US, and this population is rapidly growing, and the operations in the pediatric sites are also growing. So we have a huge population coming towards the adult hospitals. So I think the responsible thing to do for all the tertiary centers is to start to prepare to care for them appropriately and safely. So my question for you, it looks like it's going to be hard to find ACHD adult cardiologists with expertise in cross-sectional imaging to fulfill the need. So I think the institutions are going to have to think outside the box to train their providers, and one thing that I have seen done is some programs sending their general cardiology faculty as funded trainees to ACHD programs, because one of the limiting things limiting the workforce is that ACHD training is really long, and young cardiologists may not be able to afford an extra 2-3 years of training after cardiovascular disease, or even just for financial, family issues. So I have seen ACHD general cardiology providers going to train as faculty to ACHD programs. And do you think this is a model that maybe should be pursued by adult hospitals to fill the need?
I think it's a great model, but there's currently no mechanism to do that. And so through SCCT, we've offered courses, and we've done them virtual now. And the last one we did, we basically upload like 30 cases to a virtual workstation. The last course we did filled in 48 hours with people from 8 countries, and we went through like 30 cases in a day. And so you basically just marched through, this is how we did it, this is the contrast. And I think those types of things are what we need. We need to develop a really robust combination of virtual and workstation-based courses, because when you look at adult cardiac CT, there's studies showing that 75% of people that do cardiac CT for coronary disease, they learned it on the job as a physician. And so I don't think we can expect that people are going to be able to train in this and come out fully fledged. I mean, even our 4th-year cross-sectional imagers are coming in. A lot of places still don't do CT. And so I think we have to have a mechanism where practicing physicians can learn this on the job. And I think we can do it through mentorship. I really want to start a course where you'd have like online lectures. And so for the adult group, you could say, this is like the basics of transposition, this is the basics of CT acquisition, and you could, for the pediatric cardiology, you could talk about how to do it in neonate. Like the problem currently is you try to do a one-stop shop, and half of the course is completely irrelevant to half of the group all the time. Because you're an adult cardiologist, you don't actually care how to get coronaries in a 1.2 neonate, right? It's not part of what you do. You want to know how to do it in adult patients. So you really have to separate out like modules that are appropriate to what people's education and clinical needs are. And I think that's a huge need in the field, because I mean, I didn't train in CT. I went to a radiology board review course, I went to RSNA, I went to SCCT. I just kept going to every conference that I could find and trying to figure out, okay, I don't know this and I want to do it at a high level, and where can I learn that? And so I want to take what I learned and actually create that for other people, so it's a much more streamlined process and specific to this patient subset.
Wonderful, wonderful. Any other questions? Oh.
Yeah, so I think we're all a little terrified of your coronary images that we've seen today, especially because we've sort of taken for granted that, you have a negative stress test, myocardial perfusion in either an arterial switch patient, but I think you've uncovered a lot of other potential pathologies, such as patients who have reimplanted coronaries, Bentals, Ross patients, et cetera. I feel like the takeaway that I'm getting from this is that the myocardial perfusion may or may not be the right thing to do and may not be adequate in our patients, depending on what the modality is that we're using for stress. Should I take away from this that maybe CT in all of our reimplanted coronaries at some point? Because let me give the background. As an adult congenital provider, as you know, it's sometimes impossible to get op reports on these patients. And so if they have baseline coronary anomalies and then they get reimplanted with a Bental or a Ross or whatever, it just gets washed away in the history. And in particular, here in Houston, you probably actually heard from Antonio, is we lost all records when ICE happened. And so there's a whole generation, multiple generations of patients where we have no op reports at this point. So in that context then, do we recover from that by getting a one-time CT in all these patients and getting the right type of protocols for these patients?
Yeah, I don't know, because this is like sort of a new thing, and I do feel that we're falsely reassured by using the same testing that we use for adult coronary artery disease, because our mechanisms of ischemia are sometimes completely different. I do think that a one-time CT look at coronary patency is, I do that for every single one of my adult patients when I was doing adult congenital, but I think the dynamic compression is something that we just have sort of started to think about recently. And I do think that, what we're doing currently is we're putting them on the treadmill, doing the usual VO2 stuff. We're taking the mask off and saying, run as hard as you do during your sport. And so we're having them, and with that, we're starting to see some symptoms and but I think that all of these things that we do, we just took from the adult world and translated it to a pediatric world where it's completely different. And an example is that, so we actually looked at a lot of our Kawasaki patients, and I was working with John Lesser at the time. We were doing coronary CTs in our Kawasaki patients. We found like 10 complete coronary occlusions, and there was like 80 completely normal stress tests, because they develop these collaterals. And so I don't think that a stress test that you're using for an adult should reassure you whatsoever in your adult congenital patients, and I don't know what to do about that. But I think that what we're starting to do is develop protocol where if you're completely asymptomatic, if you know the operative history and you had normal coronaries, easy course, you could probably just do a single coronary CT. But I think that if you had a really rough operative course, if you're having symptoms, that kind of stuff, we're starting to do functional CTs in these. And the radiation dose, when we looked at it, was like 2.2 millisieverts to do functional. And it's less than a cath. Yeah.
You just gave me angina. And then the other question, and I think this is really relevant both for congenital interventionalists as well as the structural interventionalists, is a lot of us are now seeing the returns for valve-in-valve. And so just from anecdotal experience, I've thought a lot about that. I really want to fracture that valve when I'm doing a pulmonary valve, and I'm going to do a valve-in-valve. I'm going to ask you to sort of look into the crystal ball. For our TAVRs, for our TPVs, do you think that there's more leaflet thrombosis when we don't fracture the valve and don't maximally dilate when we implant the so-called 26 sapien?
So I work with Santiago Garcia, who's an adult cardiologist who I think now is in Cincinnati, and so we started looking at the halt information. And I think that when you think about, like with the pulmonary valve, it's low flow, it's a low velocity state, and then if the valves aren't completely expanded, I think it really gives you, like at least with a TAVR, you've got a high velocity jet coming across those valves, where with a pulmonary valve, you really don't. And so I don't know if there's data on that, but I think that what we're seeing is probably whatever is true in the TAVR world is probably going to be true in the pulmonary world.
And that goes back to the coronaries, because we may compress them when we fracture.
Yeah.
More angina. Thanks.
Thank you very much. Really enlightening, and I think you've covered most everything that has to do with imaging and workforce. Some comments and maybe a question. The comments is regarding your last part of the presentation, which is a problem for you. for the field of adult congenital heart disease. Workforce is in shortage. You guys have to do something about training programs and increasing probably the volume of training to be able to catch up. This is a complex disease that people have to spend a lot of time. I
Yes.
agree very much with your approach about training people in imaging so that you don't have you have to train the workforce that's available now. Hopefully they
Right.
have interest because it is complex. The other issue that you raised, which is very important, is the value of what you do in the current Bitcoin currency of work RVU. This is the world that we live in.
It is.
And you have to, as an organization, whichever organization, through ACC, through Adult Congenital Heart Disease Organization, advocate for such. You have to advocate for such because reading an adult congenital complex disease is very different than reading coronaries. And nowadays, you're probably going to get the same value for your time.
Yes.
And that won't happen without any major advocacy. Now, I'll share it with you, I'll share it, and because MedAxiom may be listening. You have 3 in the country, you have 3 benchmarks that you could take a look at for individuals. You have AAMC, you have MGMA, and you have MedAxiom. Most likely, the pathway that would be the best for you, all of you, I'm talking about all the adult congenital heart disease, is MedAxiom. I personally talked to the president and to the people who get the data. You have to collaborate with them to get the data for adult congenital heart disease.
I would love to do that.
And it won't happen organically. You have to have a major push to get these data from the 400 or so practitioners within adult congenital heart disease for you to have a benchmark, because you have no benchmark.
Right.
And also you have to advocate for better reimbursement, at least from an interpretation point of view, because the technical acquisition may not be very different.
Right.
But it is the time that you spend with this that takes so much time.
And it's the downstream care and the downstream revenue, I think, that can justify a lot of adult congenital programs, but for the individual practitioner that's being judged with these metrics, it doesn't help.
Believe me, you have an advocate right
I
here.
would love to talk to them. Put me in touch.
So a scientific question
Yeah.
is, I was surprised to see that your stress testing for anomalous coronaries is either imaging pure without stress or dynamic imaging and pharmacological stress.
I personally like stress tests. I like exercise treadmill tests the best, but there's a huge variability of how it's done.
I'll share with you, because these are proximal diseases, right, of a coronary. It could affect the whole left circulation.
Yeah.
Stress echo is probably your best modality because it's exercise and ventricular function. And if you have ischemia, the ventricle will show, because this is not segmental abnormalities. And you could use bicycle, where you see the graded, change, and you should have a very hyperdynamic ventricle at the end. You'll take a look at the, EKG changes and everything else, or even treadmill. I think dobutamine is, you may see contractility of the ventricle, but not the hemodynamic changes that you will see.
And that's why for that one patient that had the cardiac arrest where everyone's like, his coronaries are fine, we sent him to the adult hospital for an exercise treadmill with echo. Because I said, that's the only thing I'll trust. Because it's going to mimic the physiologic thing that he was doing when he was exercising, and we're going to see the effects of it.
Exactly.
And so that was what we did. But we're in the pediatric world, we're not good at stress testing. And so we really need this. But it's volume related, right? You're good at what you do a lot of. And so I think that for congenital or pediatric cardiologists, I think that the stress testing is actually a big weakness. And so we're trying to partner with the adult group to have us do that with an adult cardiologist where that's their bread and butter, that's their area of expertise, because we make each other better.
I think we have time for one more question, Dr. Martin.
Well, I want to say just thank you for, again, giving us a tour de force of some amazing imaging and I think question answering, and unfortunately so more thought provoking, which I think is a great thing in our field. And I do just want to kind of dovetail on the last thing that you said is, we're great at what we do a lot of. And I think that's the problem that our adult congenital world suffers from, because I think exactly what we've pointed out, there's a lot of patients, but there are few centers, but the patients aren't going to come, like all the patients aren't going to come to those 3 or 4 centers that are within their area, because that's not psychosocially and financially an opportunity for these patients, because unfortunately many of these patients are faced with all of those challenges of not having appropriate insurance, not being able to potentially be completely full in the workforce. And we didn't even touch into the neuropsychological issues that come with our adult congenital patients that, we all have to work with, but nobody wants to address. And so I think that does, like I said, raise a huge question of how do we train our groups to have them have enough volume to where they can be, competent at the same time to be able to, have them in that area of where they are. And I think, as you pointed out, this collaboration between adult and pediatrics, we as a group, I think, are working more to that, because I think we bring such different viewpoints to the table. And I think that collaborative nature is, where we will find the utopia that we will be able to find with adult congenital. But my question is to you: how do we encourage our younger people who are coming into cardiology or coming into internal medicine to embrace the adult congenital population? Because right now they are terrified of it. And also I think that the attitude that a lot of the adult practitioners say is that they're difficult, that they're not well, you're not going to be well reimbursed for your work, and that they're going to take a ton of your time, and you're not going to have the resources or the experts that you need to help you. So, I mean, if any trainee heard that message, why would they want to take that population? So how do we change that narrative?
I think that you show the passion in the promise of this. I did adult congenital because I did fetal. And then I was in practice for 20 years, and my patients were becoming adults. And I'm like, who is going to take care of them? And I was like, okay, I will build this for you if you can hire someone into it. But there was no one to hire. So then I was doing all the imaging and the adult congenital and the cardiac pregnancy and that sort of thing. And I think that when you look at the current adult congenital patients that sometimes get admitted, they are not the best marketers for our programs, because they were done at a time when we were trying to figure things out. They had tons of hypothermic circulatory arrest. They are not that functional. But when you look at the teenagers and the young adults coming through, they're like lawyers and PhDs, and they're like these completely functional people. And so I think that part of it is we have this complete separation between pediatric and adult training. I know nothing about coronary artery disease, which I should, right? There should be more crosstalk. And then if you look at adult training, there's almost no congenital heart disease in it. I think if people actually had more exposure to it when patients are functional, I think that would help. But I think there's not good role models. And I think that it is, right now, I think this reimbursement thing is a huge issue, because people are looking at it and they know that they're going to go into a situation where they're expected to do this. So you're doing 2 extra years of fellowship and often making a lot less than the normal adult cardiologist because your RVUs are low. So you have to have a really altruistic person to do that. And so I think that changing the reimbursement and some of that kind of stuff is something that has to happen. And I think that's true for all of these. The other thing that's interesting is when you look at pediatric cardiology versus adult cardiology, pediatric cardiology is kind of like groupthink. Jane Newberger did a study, it was called Deciding Without Data, and it's one of my favorite studies. She actually looked in that, they followed like pediatric cardiologists around and all the decisions they were making. They decided that less than 5% of what they do is based on any data. And so a lot of times it's just people do what they do because that's how they did it. And so I think adult cardiology is much better about changing practice and incorporating data. And so I think there's got to be more crosstalk, because once you start to do the crosstalk, I think it's fascinating and you can learn a lot. And the other thing is it's got to be in the training. Like when you look, I'm trying to, I love cardiac imaging. I think it's like cardiac art. I think it's super fun. And I love it. But our trainees, when you look at the 2015 training guidelines, even for advanced imaging, CT is not even listed as a modality. So they have all these boxes they've got to check in their training, and they really can't work with me because there's no time. And someone says, well, if you want to work with you, what are you going to take that from? And so I think that making this a part of the training, and then also I think the reimbursement piece, and you have to have institutional support, that this is important.
If I could add one more thing, whoever is listening. One is you need champions, and I'm seeing one in front of me right now, and some of the teams that we have here. Dr. Duarte, you, Dr. Lynn, Dr. Quarty. These are the champions that would move the needle. Okay? So whatever you shared with us, we know these issues, but you need a champion to shepherd this. One thing that is for you also, because when you get down to the dollars and cents, is that this is not the prevalence of coronary disease. So, and not the prevalence of heart failure, et cetera, et cetera. What I'm saying to you is that when you get to adult congenital heart disease, if you advocate for a higher pay of interpretation, of imaging, et cetera, the impact on major budgets is not huge because the population is not as prevalent
Yes.
as everything else in the world.
Yeah.
Right? So you have complexity. It is not very prevalent, yet it takes time to do the work.
Yeah.
All right. Well, thank you so much, Dr. Han.
Thank you.
For coming